Hello, my name is Ioana-Irina Rezuș, and my PhD title is Management of Pancreatic Cancer from Diagnosis to Treatment. I'm a first-year radiology resident and a first-year PhD student, joining the bilateral PhD program between Grigore Popa University in Iași, Romania, and CTM here at Semmelweis. My vision is to have a better management for patients with pancreatic cancer, and my mission is to assess new diagnosis and treatment methods and implement them into healthcare. And for that, I have two specific goals. Two studies, one that started in September this year and the other one in October. And the first study is about the efficacy and safety of therapeutic procedures for chronic pain in patients with unresectable pancreatic adenocarcinoma. Pancreatic adenocarcinoma is currently the fourth leading cause of cancer-related death, and a very big percent of these patients, 80%, are diagnosed with unresectable disease. And almost as many have pain from the point of the diagnosis and for the rest of their lives. So we can understand that the burden of disease is very high in these patients. But unfortunately, the actual available medical treatment consists mostly of opioids and is still associated with inadequate pain relief and also a plethora of side effects. But there have been emerging more interventional ways to address this pain, and our aim is to find the most efficient method that currently exists for treating chronic pain in these patients. Because when we refer to minimally invasive radiological procedures, there are actually many, and maybe the most studied one is the celiac plexus neurolysis. There are also thermal ablative techniques, such as radiofrequency ablation or high-intensity focused ultrasound, or non-thermal ablative techniques, such as reversible electroporation or stereotactic body radiation therapy. So our question is, which method is more effective and safer for pain management in patients with unresectable pancreatic cancer? And we frame it as a PICO, with the P being the population being adult patients, interventions and comparators being different kinds of pain management, as we intend to do a network meta-analysis. The primary outcomes are pain relief and quality of life, while the secondary outcomes are adverse event survival and analgesic drug use. And as I mentioned, because we intend to do a network meta-analysis, we want to include only randomized controlled trials. Our hypothesis is that interventional radiology methods can provide better chronic pain management for adults with unresectable pancreatic cancer, and the implication for that would be to have a safe way of pain relief through minimally invasive procedures. Our search was conducted on 29th of October in 5 databases, and you can see in the brackets the number of hits for each database. And the search key included 1 domain for pancreas, 1 domain for cancer, 1 for pain, and 1 for randomized controlled trials. To present you briefly some of our key articles, there is this one from Dong from 2021 that had a pretty big sample size, and it evaluates more outcomes. It's about the CT-guided celiac plexus neurolysis, but they also report some potential selection biases. Another one from Kano, this one investigates the US-guided neurolysis. They had a smaller sample size and it was not completely blinded, where this one from Yon, it compares the 2 previously mentioned, the US-guided and the CT-guided. And they could blind the assessor and the statisticians, but these procedures were performed later from the diagnosis. This is how our selection went. We started with 5,491 articles, and after duplicate removal, title and abstract selection, we reached the number of 24 full-text articles. And in the right side of this slide, you can see the citation chaser. We had 400 to 24 references, but unfortunately, we couldn't find any other eligible article in them. At this point, we are doing the data extraction, and we did 5 out of 24 articles, and we are working to finish this. The second topic is about investigating the diagnostic accuracy of different imaging techniques in pancreatic cancer staging. Pancreatic cancer has a poor prognosis, and the only chance of cure is resection, but unfortunately only 10 to 20% of the patients are eligible for this resection. And from the point of view of a radiologist, there are 2 main important parts in the diagnosis. The first one would be the early stage identification, so that those very few people that can have the surgery to go as quickly as possible to have the surgery, and also to diagnose the metastatic disease so that there are no unnecessary surgeries performed. Our aim is to find the best performing imaging techniques for local and distal spreading of pancreatic cancer, and if we will find enough, we hope to use only direct comparative studies in our meta-analysis. Our question is, which imaging technique has the best diagnostic accuracy for pancreatic cancer staging? And we frame it as a PERD, with population being adult patients. The index test will be any kind of radiology examination, the reference test, of course, pathological examination, and we will look for the sensitivity and specificity of pancreatic cancer staging. Our hypothesis is that CT provides better results for the local spreading, while MRI has better results for metastatic disease assessment. And the implication will be that we will have a better management for these patients, but also we will decrease the number of unnecessary investigations. There are some meta-analyses already published in this topic, but actually they use different methodologies than the one we wanted. And at this point, there is no prospective registration similar to ours. For this study, the preliminary search included, as in the previous study, one domain for pancreas and one for cancer, and here one for imaging tests and one for staging. And here are the numbers of hits in the 3 main databases until now. We have more key articles. Here are just a few that compare CT with MRI, but actually there are studies that compare these methods with different kinds of ultrasound or PET-CT or PET-MRI. And to sum up, I have 2 studies ongoing, which I hope I will finish by the start of next summer. I will end with a quote from George Bernard Shaw saying, "Don't wait for opportunity, create it." Thank you.
Congrats on your presentation. It's very outstanding. I would like to ask that regarding the radiological methods, they developed a lot in the last few decades. Would you like to determine years when to include these articles for your second project?
Yes, so we had a long discussion about this. We're not sure if we will include a specific year or if we will include, for example, for MRI, for example, from 1.5 Tesla and up. So I don't know if it will be like a time frame or more like see what kind of machines there are in these studies and what kind of machines they are used worldwide, and then decide exactly how we can make the inclusion criteria.
What do you think about the availability of MRI?
I think I have to read a bit more and to see, because I think there are many differences between USA probably and Europe and then other parts of the world. So in order for this study to be significant for the people who read it, I think we need to really check what is like the middle usage of these machines. Because at this point, I think 1.5 Tesla will be included.
Okay, and I have one question regarding your first topic. If I understood well, all the other modes of pain control, they are invasive methods, no? CT-guided, EUS-guided, whatever it is, it's an invasive method in a late stage oncological status. What do you think about these invasive methods as regard of pain control instead of combining other pain control, oral drugs?
Okay, thank you for your question. When we wrote this idea of the study, we also wanted to include the opioids and everything, but most of these patients also have chemotherapy and opioid treatment, and actually I think that people who come to, who reach this point of interventional methods are already over the opioid phase. And this is why they go and seek for other kinds of treatment, because of the side effects they have from the opioids, or because the opioids are not good enough for them. Because I think they're scared and nobody would go first to interventional and then try to take some drugs.
During those long considerations of methodological methods, what was the reason to discard or disregard the CT? For example, it's quite well known that the CTs of 128 slices have a lot more sensitivity.
No, but we didn't disregard them. We're comparing everything. It was just an example with the MRI.
Why don't you differentiate these data with respect to the sliceability of the CT?
So at this point, we just looked at some key articles. We didn't make any inclusion criteria yet because we didn't reach this point.
Okay.
So we will, but it's because we're not sure yet.